In this short video, we will talk about the COPD patient and some of our nursing interventions. So we think about COPD, generally this is a patient that's going to be older than 40 years old. Some symptoms that they will have will be cough. They may or may not have sputum production, dyspnea, and generally they've had some type of exposure to some of the risk factors. And our number one risk factor is going to be cigarette smoking. Something that we need to remember about COPD is that it is a progressive disease. So someone might start out with very mild symptoms, but as they get older, as the disease progresses, these symptoms will get worse. There is no cure for COPD, and basically when we talk about the treatment is really about managing the symptoms. So when you look at the COPD patient, you can kind of see, it's really respiratory focused, but the respiratory then does impact the rest of the body as well. They're easily fatigued. We're going to see them having frequent respiratory infections. As the disease progresses, you're going to see increased use of the accessory muscles to breathe. So when you're looking at them, it looks like they are using every muscle in their chest, in their neck, in their abdomen to breathe. They'll be orthopneic, which means they cannot breathe or sleep laying down because they can't breathe. So typically this is going to be the person that is sitting up in the chair. You're going to find wheezing will be a very common, you'll either hear audible wheezes, or when you're listening to the lungs, you'll be able to hear inspiratory and expiratory wheezes. Pursed-lip breathing, you're going to want to teach that. If they don't know it already, you're going to want to teach them to use pursed-lip breathing with any activity they do and with any shortness of breath that they have. This will really help decrease their shortness of breath. It helps expand the it prevents bronchial collapse, prevents air trapping, and it promotes exhalation. They will have a chronic cough. You may end up seeing a barrel chest. We already talked about dyspnea. In some cases, they'll have a sputum. You will see digital clubbing, and remember, clubbing results from prolonged hypoxia. They may also develop cor pulmonale, or hypertrophy of the right side of the heart, and that is because the right side of the heart has to work harder in order to oxygenate the lungs. And you will also see usually a very thin appearance. A lot of times they're suffering from malnourishment. And COPD really does impact the whole body, and I'm not going to go over all the things listed here, but you can expect that somebody who can't breathe, who fatigues easy, is very tired, may experience some depression. It's definitely going to impact the heart. You're going to see signs and symptoms of hypoxia and usually some cardiac problems as well. Treatment for COPD, again, will vary depending on the stage of the patient, but typically you're going to see bronchodilators. You may see corticosteroids for acute treatment, so you might see this for acute treatment, but you might also see this for chronic treatment. So there may be a patient who is more end-stage COPD who is on prednisone for life. So they take that every day. So that's something to think about when you're caring for those patients, about the negative side effects that prednisone can have on someone. For example, weight gain, increased blood glucose levels, so things to think about. Typically with a COPD exacerbation, when they come in, they're going to be getting some type of antibiotic. It might be something like Zithromax, and oxygen therapy. So patients may only need oxygen again during their acute treatment, so they might just be temporarily on oxygen, and once they get a little bit better, their inflammation or their infection resolves, they may not need to be on oxygen anymore, but many will be on oxygen for the rest of their life. So it'll be more long-term, and they will definitely need education about oxygen therapy. When we think about oxygen for our COPD patient, for many it is essential for survival. So we have to think about safe administration of oxygen for our COPD patients. So something that's a little bit different for COPD patients in comparison to other patients is that we increase our oxygen slowly. We don't just crank them up to 10 liters on a mask right away. We're going to start them out slowly and increase. So if they haven't been on oxygen before, we'd be starting out with a nasal cannula, moving up to a simple mask, and so forth. If there's somebody who's already on maybe 10 liters of a high flow nasal cannula, we would start there and increase. And we're really monitoring their oxygen levels. So if they happen to have an arterial line and we're doing continuous O2 monitoring, we can watch it on their art line, or we're monitoring it based on their pulse oximeter reading. And so for a COPD patient, we're going to increase their oxygen at 1 liter per minute. And we're always basing this on their pulse ox, not on their dyspnea. Because something we have to remember is that COPD patients are always going to be dyspneic, especially as the disease progresses. So I guess I shouldn't say always dyspneic, but remember that is one of our signs and symptoms. So it might just start out for someone to have mild dyspnea with activity to someone who then ends up being dyspneic 24/7. So our end-stage COPD patients, they're going to require high-flow oxygen, so we're going to expect them to maybe be on high-flow nasal cannulas, maybe venti masks. And again, this does need some education, so they have to know about not smoking, anything that can ignite, so gas stoves, things like that, anything that could spark and cause a flame. And they need to know about skincare, how to transport their portable tanks, those types of things. So there'll be a lot of teaching for patients who are on oxygen therapy. Other just kind of nursing, if you think about nursing interventions or assessments, teaching, those types of things, we want to make sure our patients know to avoid irritants. So if being around cats increases their difficulty to breathe and increases their risk for developing a respiratory infection, they should avoid cats. Pursed breathing, like I said before, you want to make sure you know how to do this. You want to teach these patients this. Every patient should know how to do pursed breathing. They need to balance rest with activity. So we still want these patients to exercise, and it might be, they just ambulate. Our goal might be 15 to 20 minutes per day. In advanced stages, it might be 5 minutes a day. For some people who are more end stage, well, then that would change our plan of care. But while they're still able to exercise, we want them to exercise, but we do not want them to be fatigued. So we might not be recommending an elliptical for 45 minutes. It'd be something more manageable, like ambulating. There might be need to talk about modifying sexual positions. There might also be the need to talk about using inhalers before, during, and after sexual activity. Positioning will be important for the patient. So high Fowler's position is always helpful, and tripod position is the highly recommended position for patients with COPD. So you can see by the picture here, you have a patient who looks like a very typical COPD patient, very thin, has a barrel chest, looks like he's doing pursed breathing, has oxygen on, and he's sitting in the chair in that tripod position. So anytime you can get these patients up in the chair is much better for them, because it's much easier to get into a tripod position when you're in a chair than when you're in the bed. Nutrition is extremely important, like we saw with that last patient. People become very skinny. They have a hard time eating because they get very short of breath during meal times, or if they made their meal, they're now exhausted by the time they sit down to eat. So it's best if they can rest 30 minutes before they eat. If they are the sole caretaker at their house, if they have to prepare other meals, trying to prepare them ahead of time, because if you make a big meal, by the time they sit down to eat it, they might be too exhausted to eat it. So kind of preparing ahead of time, reheating meals, easy meals. High calorie, high protein diet will be important, with snacks in between and at bedtime. Because they do get exhausted during the eating process, sometimes eating more frequently, like 5 to 6 small meals a day, is better for them. Cold foods also, you can recommend cold foods because you feel less full when you're eating cold foods, so they might be able to get in more calories that way. And it's recommended that they drink 3 liters of fluid a day, and that helps with the promoting and thinning secretions. Now, of course, if they're a heart failure patient and maybe on a fluid restriction, we wouldn't recommend that. But if it's someone who can have that amount of fluid, we would highly recommend 3 liters of fluid per day. If your patient is still smoking cessation is going to be very important. Again, it is a progressive disease, but if they quit smoking, it will help slow down that rate of progression. We already mentioned oxygen, so we want to teach them about skin and safety. Pulmonary rehab, they may qualify for pulmonary rehab, and this will be a good opportunity for them because they'll be able to go in and learn different ways to exercise. They'll reinforce the pursed lip breathing, but they'll also learn about different ways to conserve energy. So, for example, if you have to do your laundry in the basement, they'll talk about ways to, how do we get our laundry into the basement? Maybe when we're down in the basement, we plan to bring a book with us so we can sit down and read for 15 minutes before we come back up. Or other activities we can do in our basement while we just wait for the laundry to be done. Those types of things. You also want to take into consider any psychosocial considerations. Again, patients may be anxious, might feel isolated. You'll see depression. So these are things you'll want to discuss and address with your patient. You also highly want to recommend that they get the flu and pneumonia vaccine. The flu vaccine is yearly. The pneumonia vaccine is approximately every 5 to 10 years. And that's important because when we think about flu and pneumonia, the patients with the highest mortality are those that have respiratory problems. So because they have COPD in their history, it increases their risk for a negative outcome with if they acquire flu or pneumonia. So those are just kind of some key points for a patient with COPD. And if you have any questions, make sure you email me.